Dr. Edelman we'll hear more about as our visiting professor, but to introduce this topic, which is a very interesting topic, Dr. Samir Sheth, one of our fellows, will give a brief overview.
Good afternoon. I'd like to start by thanking Dr. Edelman for today. We had a great lecture and a great discussion at lunch. It was fantastic. I also like to thank Dr. Fuster, Dr. Goldman, Dr. Sharma for the entire panel today for the opportunity to sit and discuss the topic with you all. So the advancement of percutaneous coronary intervention has led to its use in the treatment of stable angina, acute coronary syndrome, and more recently, multi-vessel coronary artery disease. There were, up until recently, two broad classes of stents used in PCI. Bare metal stent and a drug-eluting stent. The drug-eluting stents contain three components: a platform, usually a carrier, and an anti-proliferative agent. The platform, usually bare metal, stainless steel, cobalt chromium, or platinum chrome. The carriers usually consist of polymers that act as slow-releasing drug carriers. And lastly, the anti-proliferative agent to suppress neointimal formation. In July of 2016, there was excitement as the FDA approved the first fully absorbable stent to treat coronary artery disease, the bioresorbable vascular scaffold system. Vascular biology has shown us that monocytes and T cells have an important role in the initiation and progression of atherogenesis. Macrophages can secrete cytokines, hydrolytic enzymes, metalloproteinases, and growth-regulating molecules. The interaction between macrophages and T helper cells can lead to chronic inflammatory response with pro-inflammatory cytokines such as IL-1 beta, IL-6, and TNF-alpha. Furthermore, pathological studies have documented that vulnerable plaques prone to rupture and erosion present as thin-capped fibroatheromas, consisting of lipid core plaques covered by a thin fibrous cap, usually less than 65 micrometers in size. Currently, our treatment with statins has been shown to increase fibrous cap thickness and make these lesions more stable, while mechanical treatment of these plaques consists of stent implantation. It is believed that the persistence of a metallic cage and or non-degradable polymer into the vessel leads to chronic inflammation and can result in complications such as in-stent restenosis and late-stent thrombosis. Bioresorbable vascular scaffolds are polymer-based or absorbable metals. Polylactic acid is frequently used in many of the stents. It degrades into water and carbon dioxide by means of the Krebs cycle. Magnesium-based alloys are an alternative, and they're usually absorbed by human tissue. Bioresorbable vascular scaffolds possess many theoretical advantages over metallic stents. First, by eliminating the presence of a permanent metallic foreign body from the vessel wall, inflammation and formation of new atherosclerotic plaques is reduced. Also, without the stent backbone, there will no longer be fear of permanent caging of a vessel or jailing of side branches. The removal of a backbone would lead to the recovery of endothelial function by increasing vasomotion of the coronary vessel. Furthermore, in the future, these stents would not interfere with the placement of a bypass graft if needed. There are many bioresorbable vascular scaffolds in clinical and preclinical trials. Most studied is the Absorb BVS system. The Absorb 3 study is the largest randomized, single-blinded, multi-center trial that included 2,008 patients with stable or unstable angina. They were randomized in a 2-to-1 ratio to receive the Absorb BVS or the Xience everolimus-eluting stent. The primary endpoint was a target lesion failure at 1 year. This included cardiac death, target vessel myocardial infarction, and ischemia-driven target lesion revascularization. The results showed that target lesion failure at 1 year was non-inferior between the groups, occurring in 7.8% of patients from the Absorb group and 6.1 patients in the Xience group. There have been several meta-analyses performed to examine the Absorb BVS system against the metallic stents. One large study that included 6 randomized trials looked at target lesion revascularization and stent thrombosis. The study included greater than 2,300 patients and found that target lesion revascularization did not differ between the two study groups, though the BVS systems had a greater risk of device thrombosis, especially in the first 3 months. There are currently a few issues hindering the widespread adoption of bioresorbable vascular scaffolds. First, the high cost of devices, which we often see in new medical technology. Secondly, none of the randomized trials actually tested a hard clinical endpoint such as mortality. Therefore, larger studies should specifically design for this purpose. Furthermore, most studies looked at one-year outcomes, and the expected benefit from bioresorbable scaffolds is long-term when the device is absorbed. The evidence shows that there's increased risk of scaffold thrombosis with bioresorbable stents, and a meta-analysis of over 10,000 patients with a follow-up of 6 months showed that stent thrombosis occurred in 1.2% of the patients, and those patients treated with bioresorbable stents were at higher risk of scaffold thrombosis. Lastly, we are still unclear on the guidelines of duration of dual antiplatelet therapy. Interruption of DAPT has led to higher rates of bioresorbable scaffold thrombosis, and very late thrombosis was increased with DAPT discontinuation. Coronary stents represent a remarkable advancement in the treatment of stable and unstable coronary artery disease. Evolution in the technology has led to the development of bioresorbable stents, proven to be as safe as drug-eluting stents, though there are still questions regarding stent thrombosis. They offer the advantage of a reduced inflammatory response, possibly reducing restenosis, as well as lowering the risk of jailing vessels. However, there is need for improved protocols for implantation with technical improvements in the devices to prove better mid to long-term clinical outcomes. There's still research to be done before bioresorbable stents become standard for most patients. Thank you.
Okay, so thank you very much, Samir, for touching into a very fast-growing field and that will be discussed today. And I feel very privileged to introduce a very unique person. We have very good people coming to these controversies. Big shots come constantly here, but today you have a very special person, and you will see in a moment why. Dr. Edelman actually was born, I learned this today. I know he's from New York, but I didn't know he was born at Mount Sinai, so he's one of us. Now, his training is quite fascinating. He actually, at Harvard Medical School, he obtained the MD degree and then the PhD at the Massachusetts Institute of Technology as a medical engineering and medical physics. So it's a good, if you have this combination in a good head, I think you can accomplish a lot. And he has been really unbelievably an accomplished man. We have him as a clinical fellow. When he obtained the MD degree, he was a resident at the Brigham and Women's Hospital, first, second, and third year. And then he spent some time as a clinical and research fellow at Harvard. And then eventually he became instructor in medicine, and in a few years he became professor of both. He was the Thomas and Virginia Cabot Professor of Health Sciences and Technology at Massachusetts Institute of Technology, and then Professor of Medicine at Harvard Medical School. So he has the two professorships. Well, at the present time, he's the director of the Harvard-MIT Biomedical Engineering Center, chair of the Harvard Medical School Faculty and Fellows Internal Grant Program, and director of the MIT Clinical Research Center. Now, if we have to enumerate his accomplishments, we will spend a lot of time, but for example, he's very highly recognized. He has been in the key committees at MIT and at Harvard Medical School. And then he belongs to the key organizations, the National Academy of Sciences, the National Academy of Engineering, and so forth. I could go one by one. What is interesting is he's in the editorial board of 60 journals. I've never seen this before. 60 journals. And you say, well, are throwaways. Sure. Science, Nature, New England Journal of Medicine, and I can go on, and Chuck. All right? So I don't name all the others as secondary. So then when you go into the awards, I don't know what to do. There are too many pages of awards, so I escaped that one, except one from Spain. Juan Carlos, the King of Spain, gave him the Spanish Order of Civil Merit for his work and for his accomplishments as an investigator. What he has done, I mean, is amazing. I mean, he has contributed so much. The first time I remember of him is when we began to look at the possibilities of actually trying to inject substances to drug delivery. So we started, we were working on this, on the stents, to see if you could deliver a drug through different mechanisms. And he was really a pioneer in the field. He has worked on polymers, in growth factors, tissue engineering, the biomaterials, tissue interactions. And then you could say, well, this is all pretty basic, and the issue of injury that he described so beautifully in a talk he gave today. But he has been a main contributor in the process of accelerated atherosclerosis and stable coronary artery disease. He has contributed a lot in the field of angiogenesis, and certainly on what has a significant future, I believe, which is tissue engineering and so forth. Well, about his funding, he will be funded forever, even when he's 105. He will continue to be funded. He gets 2 or 3 or 4 grants every year. And the one he just got is amazing, and it was already mentioned by Dr. Goldman, you know, is a grant of $75 million, not much, but you can start as a bleaching for something else, isn't it? And then the next question is the fellows that he has really trained, certainly more than 500. And many of them, which are very recognizable, they have really key positions in the country. Well, finally, what can I say? Publications. He has 275 publications, not 3,000. Importance is the quality of these publications. I'm intrigued by the first one, which was in 1977, frequency optimization for low-cost satellite communications. Well, he's working on the engineering field, so what can we say is quite justified. I think he's a unique individual, and I will tell you the following about, he got all the awards, he only has 2 to get, and I bet he will get one of them. Thank you for coming today here with us. I'm going to give you not much.
Thank you.
It's more of a gesture. Anyway, about you, and this is for outstanding teaching and expertise as the annual Sharma visiting professor in the Simon Doug. You remember him?
Yes.
Memorial lecture of today. So congratulations for being here.
Thank you.
Wants to take a picture. Yes.
Okay. Thank you. Now you sit there in the
No
middle.
time for rebuttal.
No rebuttals. No. Okay, now we are going to ask for the panel. I guess Samin is going to moderate the panel, and then Roxana Meran, Pedro Moreno, and then, of course, Samir.
I think we can take Raj also. Yes. Well, this is lot, we'll come to the clinical part, but we'll need a lot of basic help to understand. George? Oh, you had to go. Okay. All right. So, clearly that is one of the small panels today. The topic itself, as mentioned, was a little controversial. Actually, it is controversial just by the name. I haven't seen this one, but you see the title is Bioerodible Stents. So, bioresorbable, biovascular scaffold, because all these new terminologies are being coming into the literature for this absorbing stent. So maybe we just start with you, Dr. Edelman, that maybe you can say that what will be should be the right terminology for these, which actually I can tell you a few other names, few of the patients who have used. One patient used dissolving stent, actually other patient used evaporating stents. So there are a lot of names clearly in the lay public, but the BRS versus BVS. What do you think, which terminology will prevail?
I don't know what terminology will prevail, but I do know that each of these words means something fundamentally very different. So erosion, resorption, degradation, evaporation are all fundamentally different processes. And there's probably no one here that really wants to hear all the basic terminology. What they do reflect is the fact that not all materials are the same, and all materials, even concrete and plastic, will break down over time. The chemical dissolution of any material is subject to environmental milieu, and if it is harsh, then you will degrade. And if it is, for example, water soluble, then it will go away under very mild conditions. So if we're being precise, we should use being precise terms, but we're not, and therefore I don't know what will dominate. But I do think that the plethora of terms reflects the fact that we must acknowledge that all the materials are not, in fact, this one and the same.
Yeah, I mean, what we are basically using at present is with the present stent with the bioresorbable vascular scaffold BVS. But I know many of the literature, you'll see the BRS also for the same purpose, just like for the TAVI, tower, everywhere is a little different terminology. But having said that, so that is our part of the discussion today. And knowing that a lot of people here joining this discussion, are non-interventionalists. Of course, we as an intervention talk about this subject very commonly, particularly very excited. A few months ago, it finally got approved in United States, the absorbed stent from Abbott, which was available out of United States for more than 3 years. I used that in India. And so with that note, maybe I'll just start one question to you, Dr. Edelman, and that is the fundamental that we had done so much work on the drug-eluting stent. Issues used to be initially restenosis, then of course found the right drug concentration, then say, okay, there was issue about the late stent thrombosis, so got the various different combination of the drug, the polymer, and the strut thickness, and really refined the whole technique of the stents, particularly the drug-eluting stent, which became very safe. Almost, I'm sure many of you will say with your patients being taken care that the stent thrombosis we don't even hear now. And restenosis rate, yes, of course, will be there, happens in a small percentage. So the question is that when the stent technology is already so good, what do you think is driving or basic premise of the bioabsorbable stent? So stents are very good. So why do you need to change something which is so tested, so effective? We also knew that first generation stent, Cypher and Texas, look so good, but then we learned that after 1 year, 2 years, they start developing late stent thrombosis. Why the trouble? So now all of a sudden the field has been settled, so good, why do you need to change it?
So I'll answer the question as best I can briefly, and then I think it's worth hearing from the full spectrum of people here. I have devoted my life to understand the mechanisms by which we define, introduce, propel, and evaluate technology using a fundamental scheme. The most dangerous pitfall in that is assuming that what we have now is sufficient. There's nothing more dangerous in technology than assuming that what we have is adequate for our needs, because a number of things happen. First, diseases emerge, diseases evolve, or rather our understanding of diseases evolve. And the tools that we need must evolve with them. So I don't think that one, and I don't think anyone would necessarily say that the 95% of patients who did well with generation 1 stents, with the Palmas and the Palma shot stents, would have allowed us to just rest on our laurels there, and I think the same is true today. The flip side of it, though, is to recognize, and this is a cultural thing, that we must educate society, and society must understand that as we develop technology, no technology is perfect. I don't know of any technology, I don't know of any drug, I don't know of any device that doesn't have an associated risk with it, which requires first that we acknowledge the risk, second, that we explain the risk, third, that we be willing to absorb the risk, and then fourth, that we mitigate the risk. So I would be the first to admit that this is not perfect in its current embodiment. I do think that there's a necessity to judiciously study where this can go to see if it, in its current embodiment, can serve as a clinical tool, or whether it needs to evolve into something that can be used or not. And as we do so, I predict that something will come of it, and I don't know what it is, and it won't look exactly the way it looks today.
Great. So basically, in summary, that where we are with the DES far advanced in 5th or 6th generation, we are talking about the 1st generation only, at present what we have. Now, the question may be to Pedro Moreno. Pedro, tell us a little more about how the stent, when we put our DES, how do they endothelize, or what happens when the stents are placed from pathological perspective?
So initially, the relationship between the struts and the vessel wall induce a reaction that is associated with inflammation that we can quantify by the giant cells or the macrophages in the struts. We can actually quantify it on histology according to the quadrants. There is also fibrin deposition, hemorrhage, and then there is endothelization. And these 4 steps that are easily evaluated predict in some way the actual safety and outcome of the several devices. And for this, we have experience since the era of the bare metals and most recently with the BVS. And therefore, this relationship between the vessel wall and the actual strut will lead to the safety of the endothelialization. That's what we look for to stop the neointimal proliferation. That should be a healing process, non-obstructive, and about 0.1 to 0.2 millimeters of what we call late loss. So therefore, there we are. Every device has a different inflammatory response, a different fibrin deposition, peristrut hemorrhage, and endothelialization according to the complexity of this scaffolding or stent or polymer.
Okay. Now, Roger, you have been involved with so much in the molecular level and at the basic science level. Anything you want to add which is quite pertaining to where our journey of the stents have taken up from the 1st generation DES to the newer generation DES and now?
Yeah. So, I mean, obviously I'm not in the field, but I think where I see the field going is, I mean, first we have our imaging colleagues. So there's better imaging of the coronaries, and lesions will be hopefully identified in a much more specific way with these types of non-invasive methods. And in terms of the stents, I think we're getting now to a stage where once you identify what the lesion looks like in real time, you can also produce the stents with 3D printing that really fit in that lesion, and maybe depending on the kind of lesion that you have in terms of the lipids and inflammation, you can construct a stent that will fit and do the job much better than the usual stent. So now when you pick up a stent and you deploy whatever the company has given you, 2, 2.5, 3, right? I mean, and you basically inflate, and there you go. I think in the future, once you have a better sense of what that lesion is at the cellular level, size, and the type of lesion you have, you will use 3D bioprinting to actually construct a stent that fits exactly there. Now, obviously, there are a lot of issues in terms of door to balloon time and doing this expeditiously. But I think we're getting to a point where things will move very fast in the next 10 years, and I can really foresee a time where we'll be able to do that.
Great. Well, clearly the thing of future. Now, Roxana, a question to you. Knowing that in the first time you were told the stents are not good, they they cause vasoconstriction, the endothelial relaxation is affected, and that by various earlier studies shown by the first generation stent that you give acetylcholine or there was a paradoxical constriction and so. But then the other newer stents, and particularly that started with the with Jatorolimus, the stent, and then of course now with our everolimus eluting stent, that more the vessel, you still have or you restore the endothelial integrity of the vessel that dilate appropriately in most of the situations and so. So if that is the case, so already now you have the stent, yes, has done its job. The vessel is having its normal vasomotion with the newer stent design, better endothelialization. So then do we still need something new?
So, I mean, I love, Elazar, it's wonderful to have you here, and I love his answer that if we always thought that what we had was great, we'd never innovate, and that we always have to question ourselves and try to improve on what we have. So the current drug-eluting stents, there's no question about it. We've come a very, very long way from the very first generation of 2003 products where there was issues. But we're not perfect. We're seeing late events, some residual late events that we're seeing in most complex patients. We are seeing stent fractures, and a lot of, we've seen that just from the motion of the heart. And the conformity of the stent in the vessel that is caged is very, very different than one that can be freed of this. So the concept is tremendous, isn't it? I mean, I think it's very ingenious and tremendous. The question is, how do we get there, and how do we figure out, do we crawl there? Do we walk there? Do we run there? And I would say, let's take steps, small steps at a time. Let's make sure that the technology comes to where it needs to go, as you pointed out. And remember that as good as we think we have it with a metallic stent, with the thinnest struts that they currently have, we still have residual events. And we're coming to a place where we want to say, can we overcome this? I don't know if bioresorbable, biodegradable, whatever is the answer, but I certainly like the concept. I think it's intriguing. What do you think, Elazar? Is that too far, too dreamy?
No, I don't think it is. But I think inherent to this whole discussion is how you perceive the advance of technology in medicine. We unfortunately have gotten to a point in medicine where society is not willing to assume a risk, and we're not willing to acknowledge that we don't know everything and cannot be perfect, but that we need to test innovation in order to advance innovation. Devices are very much unlike drugs. You have to build it in order to test it, and you have to test it to prove that it's safe, and you have to prove that it's safe in order to prove that it's effective. That's very different than drug development. So there's no other way to get to a place as to change the materials than to actually consider these as therapeutic alternatives. And it may very well be that we accept them or that we reject them, but I don't know any other way of going about this process without at least considering the alternative. I mean, I do actually vividly remember the day when we were challenged that second generation stents didn't show benefit compared to first-generation stents. And that it took a huge amount of effort to actually show that innovation actually had impact. So I agree with you, but I do think that we need to be careful because we need to educate people as to exactly what we're doing as opposed to just saying that we're introducing the next best thing.
All right, Samir, coming around with the question to you on the same topic before we go on further on, that from your point of view with your study of this literature, right hot off the press, from the, what will be the one most important limitation of the present DES, which will say that, okay, now we need to go to some different technology.
So as we've been discussing, and that there's always a need to push innovation and push new technologies. And I think with drug-eluting stents, we see that there are many cases where we are not stuck, but we're deciding to put a stent in another stent. Or we have young patients who come in with acute coronary syndromes. They have a stent at the age of 35 or 40. And in these stents, we're just seeing progression of atherosclerosis. It may not be thrombosis or in-stent restenosis, but we're seeing just the progression of the disease. These patients are getting stents at a young age because they have a high burden of disease. So I think an interesting area for these stents may be that what if a patient who had a stent at a young age for a STEMI needs a bypass down the road, or putting in another stent in a stent or a third layer in a stent may not be wise, putting them at a higher risk for thrombosis. And this may be an ability of these newer generation maybe to tackle these problems. And again, it's going to be progressive innovation in these stents before we can tackle some of these problems.
Yeah, one of the most common reasoning behind, I would say, as you saw from the discussion, that of course we want innovation. One of the words which drove the innovation is that even if you put a DES, 1 year your restenosis became, let's say, remained fine, 0. But now, every year, about few percent of the point, you'll have a trouble with that stent, whether it is for delayed restenosis, delayed thrombosis, or the neoatherosclerosis, which many things are being talked about. And the whole concept now is that maybe if you didn't need that stent after 1 or 2 years, maybe that percent point, 2% event per year will decrease or go away. Whether it's true or not, of course, the trials, we will discuss that subsequently. So I would ask everyone, all 5 of you, one single thing in a stent, which you think over the years, we're not talking about the absorb, in the DES, what really made, it's not the drug effectiveness, we'll say, well, maybe everolimus a little more effective than the zetorolimus, and that I think is a minor and so. Not the drug itself, but stent design or other, what is the most effective, the evolution which has been done with the newer generation stent, which has led to where we are. That is, very low restenosis and very, very low stent thrombosis, because most of the current DES studies have shown 1 year stent thrombosis, and these patients are very carefully followed, less than 1%. So anything new you want to bring, you need to compare against it. So whether it's a 0.5% or 0.8%, 1 year thrombosis rate of less than 1%. So I'll start with Pedro. What do you think the most important in the DS technology which made this difference?
I think strut thickness, for me, is the crucial component that may drive the good outcomes on sometimes bad outcomes.
Roxana?
Well, I actually think it might have something to do with the polymers and the inflammatory response to that polymer. And it was great to hear Elazar today about Louis Pasteur, cause and effect. And is it that a polymer reacts differently in a different patient based on their biology of their vessel versus a biodegradable polymer or a fluoropolymer or what have you? Certainly strut thickness does have something to do with it, but I believe it looks to me that that could be the driving force.
Alistair?
So I would have to answer the question by being political and saying that there is no such thing as a single factor, because the stent is the confluence of many factors. And at the end of the day, I think it's the design of the device. But the design of the device includes the dimensions and the surface and the structure. And where we have evolved is to the point where we're getting the confluence right. If you put my fingers in the fire and ask for one thing, it would be a design which allows for the device to integrate in the most flexible manner within the vessel wall. And in some cases, that is dictated by its dimensions, and in others by its, the way in which the struts are integrated.
Samir?
I'll go with a confluence of factors also.
Good answer.
I'll just say one word, geometry. I think it incorporates many of the.
Because I think there are various factors. The strut thickness was one of the big ones that really led to, after the original stereo trial, that thinner the strut, better endothelialization, less intimal hyperplasia, and less inflammation. And of course, the polymer had a lot to do, because same drug with a different polymer, similar kind of stent will have a different outcome. Okay, so now we got to the DES, we have some limitation. Now we get to the bioabsorbable stent technology, absorbed stent with us, and showed that, as Samir pointed out, the studies have been done, and it is coming out non-inferior to our drug-eluting stent. But this is again with a short-term follow-up of 1 year, or some studies by 2 years. But there are some limitations. So clearly, so the Elajar, now it's your, you do enlighten us about this, the current problem with the absorbed stent, and what do you think will be the answer?
So I think it's indisputable that the way in which these first-generation devices were used generated more acute thrombosis than nth-generation drug-eluting stents. What will be required is to combat that is a two-part question. First is to ask whether it's possible, which I believe it is, and then second, what needs to happen for that to occur. So first, we'll need to understand what the optimal way of placing these devices. Whether you call it a scaffold or a stent, is immaterial. It still has the functional requirement that it interact with an artery so as to preserve luminal diameter without creating a tissue reaction which is destructive either by being hyperplastic, thrombotic, or inflammatory. Now, there's no reason to assume that plastic and metal are the same, and yet we don't know any better, and therefore we have to place these devices the same way, even though they're dramatically different. Which means that we either make the plastic or the polymeric material devices to look like the metal stents, which they don't. They have twice the foot pad, twice the number of struts. They, roughly speaking, depending upon the design, they're dramatically different thicknesses, almost twice the thickness. So you either change the design so that they look just like the metal stents that you're placing in a specific way, or change the way in which you implant the devices. But you can't have it both ways. And so right now, where we're at the starting line, we can do any of a variety of things. And so we ought to look seriously at the material, look seriously at the geometry and the design, but look at the way in which we implant these devices, prepare the artery. When we did the study for drug-eluting stents, the thing we found was, and I want to remind people, there was such a mania when drug-eluting stents came out, they were thrombotic, that we were all called to the FDA for an emergency panel meeting Denmark had pulled all of the drug-eluting stents from their central pharmacies, and drug-eluting stents were not available in Denmark. And we were in danger in the United States of losing drug-eluting stents. So what it would require was judicious work preclinically and clinically, and what we showed was that strut thickness and apposition were far more thrombogenic than the material itself. So now I think what has to happen is, having had the clinical experience, we need to go back to the preclinical, which is exactly what we've been proposing to FDA for all of their technology assessments. Use the clinical experience to go back into the controlled environment of the bench, the computer, and the animal to ask fundamental questions, and then revise the clinical protocols, and then revise the devices, and in a cyclical, iterative fashion, allow for technology to naturally evolve and advance itself.
Back to the future.
Yes.
Okay, so as was mentioned in presentation, was that at present now, we actually have many randomized trials comparing the absorbed stent, which is, although other stents are coming up with the small studies, but absorb has the largest literature with the numerous randomized trial or 20,000+ cases and so on and so forth, and basically coming out that it is slightly little higher TLR, but non-significant, maybe with a 3%, with the DES it becomes 4 or 5%. But consistently, in the studies, that double the incidence of scaffold thrombosis. So it's not a stent, so we are calling it a scaffold. So there is a new terminology going on now, that rather than stent thrombosis, which we say ST, now they call it SCT, scaffold thrombosis. And it's about double, whether it's a 0.5 to 1 or 1 to 2, and so on and so forth. So Roxana, question to you is, what do you think is driving it? That, of course, that is whatever our experience, these are the trial data, that why we noticed or observed consistently, I would say majority of the trial, the double scaffold thrombosis compared to the DES thrombosis.
So obviously, that's the $64,000 or $1 million question. But importantly, and I think that this was what I was most impressed with Abbott as a company, where they really tried to understand this within their own data. And one of the things they found consistently, that the thrombotic events, the target vessel myocardial infarctions, and the scaffold thrombosis was clustered in the small vessels, the very small vessels, the vessels that should have never been in the study to begin with. The vessel sizes were supposed to be 2.5 millimeters in diameter, and a good percentage, about 20% of the time, there was a vessel size of 2.25, 2.19 by Core Lab. And despite the fact that they put in these scaffolds in the small vessels, you can imagine with a thick strut of a bioresorbable scaffold, there's not much headroom left, and so that there could be some thrombosis. And indeed, they did find that. There was a tremendous interaction, and it was, and accordingly, presented very transparently to the FDA, and they showed that there was this issue. Now, having said that, notwithstandingly, I think we all need to understand that we only have 1 year data in large numbers of patients. Even if we exclude those patients, we still need more evidence to feel confident that this result will hold up and that there won't be an issue with scaffold thrombosis. And now we're getting more and more data. And I think next month in our big meeting, we're going to see more data, and hopefully we'll be more happy with the data as it comes along, or we'll see if there's an issue. But certainly it was the small vessels, big, a scaffold put into a small vessel, clustering of events there. And when you exclude those, you see that there's no issue. But we all know that when you start excluding things, you're not really feeling happy 100%. So I think that, there is that little bit of uneasiness. And that's why I think the company has been very, very, again, responsible in how they rolled out this device. We know that patients love it. They come and ask for it. And we tell them, It has to be the right size. We have to do imaging. We have to do we have to make sure that your artery fits this stent, if you will. And I think that's what's going on.
Okay, Pedro, what do you think? It's just the vessel size, or there's something else which drove of the new, I would say, nascent technology?
I think the vessel size magnifies the deployment under the conditions that we used recently in the era of the DES. DES were very permissive because, as Dr. Edelman highly say it, we just learned that these vessels are permissive. So we used not to do predilation. We think it's a 3-0 vessel, so we put a 3-0 stent. It's a 3-5 vessel. So stent malapposition and incomplete expansion were not really focused on the deployment technology or the technique that is used around the country and around the world. Of course, if you don't prepare the vessel and you have incomplete expansion that you may not see under fluoroscopy because these stents are radiolucent, so you don't see incomplete expansion that you may see with a regular stent. Or if you don't prepare the vessel properly and you do malapposition, in other words, you put a 3-0 stent in a 3.5 vessel, you will have more trouble. What happened? The large vessels are forgiven because the rheological and the virtual thread that I learned from Dr. Fuster allows you sometimes, if you have good flow, to go alone. But in the small vessels, stent malapposition and incomplete expansion are not forgiven. And it's not that we have very high incidence of stent thrombosis. It's between in the 2.5 or less, we may go to the 2%, 2.5%. But still, as discussed earlier, this is not rather forgiven by society. And therefore, I don't think it's only the small vessels, it's also technology. So we need to predilate properly the bulk, so we prepare the vessel properly, we do one-to-one deployment under imaging, and we post-dilate aggressively so we don't have malapposition. With those 3 techniques, I am completely sure I will actually allow my LAD to have one of these DESs, one of these BVSs. Because if I have a problem down the road, especially in the mid-segment, proximal, in the mid-segment and big distal segment, I just had 2 patients last week. One has 3 layers of a stent in the mid-distal LAD. 3 layers, and again, restenosis by OCT, beautifully displayed. The other patient had a lima to the apical LAD, no return reflow to the mid or proximal. So the left main bifurcation, I had to, rotablate and put 2 stents because the angina is unbearable. The surgeons will operate whatever we give them. So they hook the lima to the distal, to the apical LAD, which will save the apex, but will not feed the diagonals and the septals. And therefore, long story short, I clearly see the need, the clinical need, which we have not discussed yet, for this device, unquestionably. Specifically in the vessel where revascularization has shown survival benefit, mostly with surgical revascularization. But also, I see how it has to be deployed. And it's been published, that this technology has to be deployed appropriately.
Yeah, clearly, as has been highlighted, compared to our DES, we go, dilate, or even not dilate, pre-dilate, put a stent, go a few seconds, 5-10 seconds, and come out, looks great. And actually, there are enough data in the DES literature that the malapposition is questionable whether it caused late thrombosis or so. But with the BVS, the story is a little different. It's a lot of data have shown that the malapposition is the one maybe a factor. So the techniques are different. And actually, there is a paper, in JACC about 6-8 months ago, which 3 institutions in Europe, they compare their earlier experience, and then they put together a BVS-specific deployment protocol, and which involved all the factors which Dr. Moreno just highlighted, that identify the vessel, pre-treated, then appropriate size stent, and post-dilate. at high pressure. So don't be afraid, because key is that in the beginning, everybody used to be afraid that this is a plastic stent. You go to very high pressure, you'll break it and destroy it. So it's not the case. So clearly that led to that by those investigators, 3% stent scaffold thrombosis became 1%. And 1% we know is similar to our drug-eluting stent. So clearly this part continue. Now the second and very important point which Dr. Alazar, we want you to highlight, the big concept that the stent will dissolve or scaffold will dissolve and artery will become normal, whether it takes 3 years or 5 years. Do you think it is true? Or will it be true?
I mean, the data suggest the following. The complications occur well before the stent dissolves. So complications are not from the dissolution, and we haven't looked at the signature of dissolution. We have absolutely no idea what's going to happen to a vessel that had ongoing inflammation for 3 to 4 years in order to allow the stent to go away in terms of when it returns to normal. So I could see both sides of the equation. I could see very easily making the argument that the dissolving material takes a foreign body that is residing in the artery out of the artery, and then at some point in time it returns to normal. On the other hand, I can't argue with those who say you have a fairly inert metal sitting in an artery. We know that at 6 months, most of the reaction is gone and done with. But the only way in which to have dissolution is to have active cellular processes, hence inflammation. And that inflammation has to continue for as long as there's any foreign material there. And so until the material is gone, and likely for some multiple of half-lives after the material is gone, the artery cannot be deemed as normal. If it takes, therefore, 3 years for the material to go away, then it would take 6 or 9 years for the artery to return to normal. And this is where our obligation comes in. It's one thing to make the arguments on one or other side of the equation. What we need to do is to define which one is the case.
Roger, do you want to highlight on this, that why this material is getting dissolved and not causing any inflammation?
I mean, Alazar said it very eloquently. I mean, the issue is how do you balance these two things? I mean, they're two opposing factors. We're talking about inflammation within the vessel that we know can cause a disruption of the normal physiology of the vessel. Then you need inflammation to actually resorb and have a steady state with exit and of the material into the blood flow. So I think it's a very tight rope that scientists and engineers have to work on. And these clinical data that we're getting, as Roxana mentioned, are extremely important, because these are will help with the future design of these bioresorbable stents.
Now, Samir, how convincing you are by reading the literature that the artery which got the BVS after 1 or 2 years regain the vasomotion?
So I think at this point, as Dr. Edelman mentioned in his noontime talk, that each process is different in each patient. So we can see that we hope that they dissolve in 2 to 3 years. It may be a little longer, a little shorter, and as a certain processes go on in every patient. But I think that what I've seen from the literature is that when still early and they haven't been able to measure it long term, the vasomotion or vasoreactivity of vessels, I think that with these, there was increased vasomotion at 1 year compared to the drug-eluting stents in one study that I did see. But again, I think long-term, as we're talking about, we just don't know. It could go either way.
Yeah, I mean, clearly some data have shown that the response of the arterial segment to the acetylcholine the disease artery cause vasoconstriction, the normal segment should dilate, that in absorb a small study, that when you give acetylcholine challenge at 6 months, 1 year, or 2 year, actually nothing happens at 6 months, 1 year. It's only 2 years when you start seeing some vasomotion, largely because by the time the integrity of the scaffold start disintegrating. Because as long as the scaffold is there, they still remain the same kind of, may not be tough metal, but clearly. But yes, it seems to be that is one of the premise. So basically, few premises of the absorbable stents. One is that artery will get a normal vasomotion. So some data, yes, but I think we still need to hear more, right? We need to see some more in a large data set that yes, the vessel vasomotion is arrives after some time. Then the second issue remains that once the drug, the scaffold is gone at 3 years or so, the artery, which has been shown by OCTs, that you don't see the even ghost except those 2 metal elements which are on the stent, rest compared to the metal which you always see with the DES, you don't see it. The third issue which clearly at the forefront is the stent deployment technique, which are really very different. And of course, if you do it well, maybe better apposition compared to with a regular DES, which is very easy to deploy, takes extra time. But if you do it correctly, hopefully it will have a great results edge to the DES. So coming back to the points then, now let's come back to, okay, we got a good size vessel, we have the best technique to do the absorb stent. Which patient should get the absorb stent? Everybody or selected group? Elijah, will be yours?
We don't have enough information. I mean, there's no, you put in more devices than anybody I know. So really we should ask you that question. But I don't view it as 5 years from now, these are the tools we'll have. We'll have different erodible materials in some form. And so I can't answer the question, because by the time we know how this generation works, we'll already have modified our technology, which again is a double-edged sword, because then we'll have a different unknown. But at least we'll know a lot more. So for now, you've heard experts in intervention say you have to change your preparation and post-dilation protocols. You have to choose your vessel wisely. And we really don't know about other subsets yet. So once the data are out, I'll be able to answer the question.
Well, Pedro already said that if there is a proximal LAD, he'll get the absorb stent. Now, although Sanjay Kaul, as you know, in the news has said a few times that why would I need? I will go with the DES, some people. Roxana, what will be the group?
And I think at the moment, I would be, again, choosing the patients judiciously. And if you look across the board, in high volume labs, it's about 5 to 8% of the patients. So it's not everybody, it's not every LAD. It's a well thought out, judicious way to move forward until we have more data. And as Elazar said, I think we're going to be in a different place a few years down the line. Already, Abbott is working on a thinner strut, next generation absorb stent. We're going to see more data as we go forward. In the next year, we'll have 3-year data for absorb 3, which is the largest trial up to now. The ongoing absorb 4 is going on. In the meantime, there's large numbers of patients who are receiving the absorb stent, and there's judicious follow-up on these patients, and we'll learn more and more. Today, as we speak today, I think we have to, again, walk and choose carefully the right patient. Very important aspect is to be sure that your patient, because of the dual antiplatelet therapy issue of not knowing how long you should be giving dual antiplatelet therapies to these patients is another factor that comes into place. And I think we need to think about that at the moment. If the mandatory period is at least 12 months, and we don't know beyond that whether these patients need to be on a longer regimen, that's something to think about. In a frail little lady who's got a large proximal LAD, I may not put them in because of the dual antiplatelet therapy. So again, it's a lot of factors. It's not just a particular factor.
Samir, which case, Abjor, you'll recommend? Your patient or yourself?
Again, again, I would say maybe at this point, if it's there was a trial looking at ACS and then STEMIs, maybe in younger patients, it may end up becoming beneficial if there's less stent thrombosis with maybe an LAD STEMI or RCA STEMI at that point in a younger patient maybe. But again, I can't say for sure right now.
Oksana, you want to say?
One population that I really do think this is the population we should use, again, with judicious, is the patients with multiple in-stent restenosis in a large vessel. I just think that keep putting in the same layers and making club sandwiches in a small artery may not be the best recipe. Now, at the same time, you're also concerned because, again, there's not enough room there and the struts are thicker. But I'd love to see us study this again forward, making sure that it's not an underdeployed stent, do very good vessel preparation, and then put in a bioresorbable scaffold.
Roger? Yeah.
I actually would not. If they have a large enough vessel, they're diabetics with large vessels, then I would think about putting them in. And again, once again, I think we are, moving. It's a small population, but it's a growing one as we learn and become more familiar.
So the trials are including all comers.
Yes, all comers.
Right. So what Dr. Edelman asked, our experience at Sinai, we were part of the Absorb 3 and Absorb 4. Dr. Keeney being the PI, we had done about 60 somewhat cases in the trial, and since approval, about similar number. But since approval, just to understand the whole mechanism that what is the best technique, 95% of cases we have used the imaging technology, particularly OCT. So just to see that a stent is being fully expanded, and sometimes there are edge dissections, small, have been covered by the additional stent. Also, clearly we have used some cases with the patient with the in-stent restenosis and have avoided generically 2.5 millimeter vessels. So that we have not used the 2.5 millimeter Absorb stent. So just to come back to the point that those may be the right patient population. And that is the large vessel, proximal vessel, and till we understand a little better, because many times the vessel, knowing that the scaffold expansion of this bioabsorbable stent is very important. So you really need to expand it, and that can only be helped by angiography, not by angiography, additional imaging, whether you do IVUS or OCT. And this is, so our experience so far, we have found there's no issue have been in terms of this 100+ cases in our trial experience in Mount Sinai of any scaffold thrombosis or so. Now, with the time we have less, so that I will now ask any questions from our audience. Yes?
Well, it's been a delight to listen to the perfectibility of devices. I was thinking that it's really not surprising that after a year things begin to fall apart progressively, because we are not yet at the perfectibility of this act. We have billions of people on this planet who don't need any stents. And the point of that has to do with the fact that we have only slowly evolved the perfectibility of risk factors. We used to think in 1976 that you didn't need to control risk factors until you had angina or heart attack. Now we're striving for 100 milligrams per deciliter in LDL, but we now know there are two groups where you have to go down to 50, because that's in fact where the mammalian LDL is, between 50 and 70. So every patient that we get to 100 and feel comfortable is a compromise. And therefore, I believe, at the same time we're talking about perfectibility of devices, we should take note of the fact that we're slowly evolving toward the perfectibility of risk factors. The problem that we're seeing in growing populations in global disease is the fact that we're introducing more risk factors.
Well, I mean, Dr. Wolinski's question is more generic and more with the overall taking care of the patient, but clearly this issue about absorbed stent, what we learned means that the time is up. That probably was the bell ring, so it's a modified way to say. But the key is that one thing clear, this is a new technology which need to mature, very simply. So we trying to understand. So actually for any other question on to our expert panel on this issue? Maybe, I know Dr. Fuster did not take part. Maybe Dr. Fuster need to comment, but you need to comment a little bit on this subject. How can we have the evening controversy without your comments?
Well, you know, I'm speaking now as editor of a journal. During the last 3 years, we had 50 papers dealing with the issue. And frankly, the problem is it changes from paper to paper. So it's changing so rapidly that to have a clear feeling where this is going, frankly, at least from my point of view, I am very nebulous. For example, the issue of thrombogenicity, which was going to be very clear, but this type of technology is now becoming complicated with thrombosis appearing late in the process, why this is happening. So it's a very exciting field, as you say. We have to move forward, but it's very difficult to know where it's going, frankly.
Dr. Sharma, I have a question for you. What do you do when your referring physicians send you a patient and say, we want you to put a bioresorbable scaffold in this patient?
Yes, I think, just overall, although once the device came, my prediction was that we'll have about 10% use, but it comes out to be around 4 or 5%, because just same, the issue about thrombosis, everybody is concerned, so till we get more experience. So we tell exactly to the patients, both patients or referring physician, who is the appropriate patient. And that is the patient with the vessel of 3 millimeter and above. Even calcified or no, that's not an issue. We actually have live webcast 2 months in a row where we use the overlapping stents after rotational atherectomy in the bifurcation cases. So we are taught what the various techniques are. So, but key is that appropriate patient and younger patient. So we have made a cutoff of 65 because I think the whole many benefit which we have talked here of the dissolution of the scaffold and the normal restoration of the vessel, you don't worry about that at age of 70. You definitely worry about the younger patients. So keeping the device for the younger patients and clearly the proximal to mid segment of the vessel, irrespective of the lesion calcifications or so. So just basically because our center is very good at doing the rotational or orbital atherectomy in these calcific lesions. So cases which I described of 60, around 60 at Sinai after the approval all include those patients. So I think if we sum up, and of course we'll ask the two important questions there. All right, George.
Yeah, well, I know Dr. Wolinski alluded that perhaps if we do a great job with risk factors, maybe we need no stent. But given that we're not exactly there yet, and many people don't like to take long-term medical therapy, and that's another fact we have to face as doctors, and I'm sorry, perhaps you've already discussed this when I wasn't here. As a take-home message, what could be the feature of the ideal bioabsorbable scaffold in the foreseeable future? What could that be? Because we said about the iterations, limitations of this one, maybe others coming up. But in general, what would be the ideal goal to shoot for that? Because indeed, it is somewhat appealing to have something that goes away, potentially allowing you to have a bypass target or other aspects.
I think it's clearly directed to you.
Thank you, George, for at the end of the day asking a question like that. Look, I would define the ideal functionally rather than technically. So the ideal approach, I always believe, is the confluence of all the things that we do well. Part of the one brave idea is not to focus on patients who've had catastrophic manifestation of the end stage of disease, but to get to people as early as possible, to modify risk, as Dr. Walensky said, and Dr. Fuster has taught us and is teaching us. So if we apply that to the device, we have to, if we're going to use devices, think about a device not in terms of what materials they're made of, or whether they do or do not release drugs, or what drugs they release, but rather, how do they operate? And so the ideal device is that device which can provide the maximal luminal diameter with minimal reactivity. And we know how to measure those things, and it's incumbent upon us to define that. And whether that means that the entire device erodes or some portion of it erodes is yet to be determined, or none of it erodes. I think it's an unknown question, but we do know what the ideal is.
Yes.
So, a final question for LSR. One of the most appealing hypotheses now in athero is the concept of resolution of inflammation. And, also, let's say for angiogenic-driven diseases, resolution of angiogenesis, looking for health instead of disease. Do you envision limitations in the time frame in the resolution of inflammation with the BVS?
So, are we talking about BVS as a specific technology, as in the absorbed stent, or in a class of materials that erode? Because I would say we shouldn't talk about first-generation technologies. I think we need to talk about erodible materials. So I'm a firm believer that you do a lot better if you mitigate the damage up front than try to stem the tide that you released by causing a substantial amount of damage downstream. Whatever happens has to be such that it doesn't create a huge amount of vascular injury because it requires a greater foot pad or greater perfusion, inflation pressures, that it has minimal recoil, because in order to combat the recoil, we know we have to have higher inflation pressures, that the device geometry and design have to be optimized. And if it means that the only way to get an erodible material in is by sacrificing all of those things and having prolonged inflammation, you're going to have a multiple of half-lives to see full recovery. So the short answer to your question is yes. Unless we're capable of perfecting erodible materials so that they cause the same amount or lesser degrees of damage that it takes to put in a drug-eluting or bare metal stent, they will not be a viable technology. And we may be focusing on the wrong thing. It's how much damage we cause up front that will dictate what happens downstream, rather than whether it goes away after some period of time or not.
If any other questions, I think we are reaching. Let me make the last statement, what the BVS technology at present is, which I put in one of my webcasts, that the technology is at present, what we are doing now with the BVS is, it's a small short-term sacrifice for a potential long-term gain. Whether it will be true or not, time will tell. Thank you very much. Thanks.